Chaudhary. So today,
Yeah, go on, Shrutika. Who's that? Sindura.
yes, ma'am.
Mm.
So today we have Dr. Anita Borges as our speaker. As you all know, she is a consultant pathologist in the Center for Oncopathology at Tata Trust, Mumbai. Today is a unique session where, although we don't have a slide seminar, it is meant to be an interactive session. We have 9 postgraduate students here with us for active interaction with Madam. So we have Dr. Anvesha Chaudhary from AIMS BB Nagar, Dr. Aishwarya Javalkar from GMC Nizamabad, Dr. Sikandar Purohit from KMC Manipal, Dr. Krishna Arshita from SPMC Tirupati, Dr. Sumita from MMC Chennai, Major Aniz Ali from AFMC Pune, Dr. Ujjwal from TMH Mumbai, Dr. Gurutej Singh from Uttarakhand Medical College, Srinagar, Dr. Tejas Vaidya from PDU GMC Rajkot, and this session is moderated by Dr. Suchritika, consultant hematopathologist at Jaslok Hospital, Mumbai, and I, Dr. Sindhura Lakshmi from KMC Manipal. And webinar hosts are Dr. Anita Borges and Sumit Gujral sir. So a few reminders for all of you. If there is an interruption in your connection, or there is low or no sound, or in case of video freezing and video lag, please leave the meeting and rejoin with the same link. And if the problem persists, please check your internet connection. If there are any poll questions, please answer by typing in the chat box. And please don't send requests for annotation to the presenters. And there are a few disclaimers. And a few more. Okay, just a brief on upcoming talks. After this talk in the next, on coming Thursday, we have a slide seminar on bone marrow aspirate smear examination by Dr. Rakhi Kar and Dr. Devdatta Basu, both from Puducherry. And on 8th August, the second part of this today's talk will be held by Dr. Anita Borges, Madam. Please join in for that as well. And now, without much ado, I hand it over to you, ma'am.
Thank you, Sindura. Thank you very much. Okay,
Yes,
and I want to thank all of the students, 9 of them, who are interacting during this slide seminar, because it's not very easy to be interacting over here, because you feel relatively exposed. All the rest who are sitting behind the scenes are learning a lot from the interaction that goes on between the speaker and these students. And also I say that when one makes a mistake, not just the student learns who has made the mistake, but everybody else who is witness to this. So I thank all of you for having agreed, volunteered to come and interact with this. Okay, so today is let me just start this. Okay. I think you can see my screen.
Yes, ma'am.
Yes,
Okay. So this is Neoplasia part 1. Now, I did say to the students yesterday when I met them, I mean, they were curious. What is it that, they need to do during this, this talk? Because I'm going to talk, and everybody is going to listen. That is without a doubt. So what are they going to do? Well, I believe that lecturing, that teaching is one thing, but learning is another. And as I said to them yesterday, learning is a very, very active exercise. All right, you do not learn if you only wish to be passively taught. So that's what they're going to do, and we're going to ask a lot of questions which will test the understanding of whatever we're going to talk about, the concepts in particular. Okay, so I'll just start with this. And the first thing is, I'm sure that all of you over here, the students here and those who are there know what, at least have had some understanding of what is neoplasia. And I just put down some of these facts that people believe are facts about neoplasia. It's there in all the textbooks, and it is taught by by a lot of teachers, and also when you're a senior resident or whatever, you teach your junior residents, you teach second MBBS students, and we know that the definition of a neoplasm is what is put up over here, and it's the standard definition of what a neoplasm is, and I'll just read it out. It is an abnormal mass of tissue, the growth of which exceeds and is uncoordinated with that of normal tissues. And the things that I believe that are to be stressed and are stressed in all definitions are these that are I have depicted in red. Abnormal mass of tissue. It is growth. Growth is a very important part of this, and by growth we mean that there are a whole lot of cells, and that growth exceeds and is uncoordinated with that of normal tissues. And even more interestingly, most of our definitions talk about this mass of tissue persisting in the same excessive manner after the cessation of the stimuli which evoked the change. Now, if there's anyone amongst you students over here, who says that that they haven't heard this definition, then please let me know. Okay. Otherwise, what we understand about neoplasia is this definition. Then we know that, at least we believe, that a neoplasm arises from the clonal expansion of a single neoplastic cell. So we talk about one cell and all its progeny that expand by division, otherwise you cannot get growth, and you will get a progeny of all of this single neoplastic cell, which then form the neoplasm, right? And that then there are different kinds of, at least two kinds of neoplasm. There are benign neoplasms, and there is cancer. And cancer is believed, that's how we define it, is that it is a malignant neoplasm. There are many kinds of benign neoplasms and there are many kinds of cancer, but it is not my, see, once again, there's somebody who's asked for an annotation request, and I'm going to decline it. Arshad and whoever else, who's going to be here, I think by mistake you touched the top of the screen where there is a little squiggle. The moment that you touch that, I get a request for an annotation. Okay, so please be a little careful about touching that little thing that looks like a small snake or a worm. It's on the top right-hand side corner of your screen. So please don't do that because it disturbs me, it disturbs everybody else. Okay, so cancer is a malignant neoplasm. Okay? We also are told, and it's there in most textbooks that you read, that cancer is a multi-gene disorder caused by somatic mutations. Yes, and then if you open some of the, better textbooks, it says there that cancer is defined by hallmarks, and I'm sure all of you know that. And the students who are here interacting with us, I think they went and did a quick read of the chapter on neoplasia because that's what I told them to do. And I hope they've done it. And then there are, we all believe, and as pathologists, we have to believe this, that there are consistent differences between normal cells and cancer cells. Otherwise, what are we doing in pathology, right? You might ask yourself, if there are no differences or the differences are not consistent, then how would we be able to tell a normal cell from a cancer cell? Okay, so we, all of this common understanding of neoplasia, and the last point is more or less the same as the previous one, and that is a cancer cell is definable. It is definable by and of itself. Now, this is the common understanding of neoplasia. So let us go through all of this and see, is this actually what we come across in our everyday pathology? And is there a need to add or subtract something from this common understanding of neoplasia? All right, so now let's start with the definition. What's happened? Okay. And this is the definition of a neoplasm. I just read it out to you. Okay. And then it says, I just added a little bit from Robbins, and that is fundamental to the origin of all neoplasms are heritable changes. That means one cell, when it divides, it gives rise to two cells, and those two cells inherit what the original cell had. So if there was something abnormal in the genome, its progeny will inherit it. That allow, and there you see excessive again, and unregulated proliferation that is independent of physiologic regulatory stimuli. So let me ask again, is everybody happy with this definition, or does somebody disagree? All right, let me start now with the A's. Okay, Anis,
Yes, ma'am.
you're happy with this definition?
Yes, ma'am.
All right. So now let me go through all 9 of you. Let me see if there's anybody who disagrees. Okay.
Ma'am.
Aishwarya, you
Yes,
agree?
ma'am, I agree with it, ma'am.
Oh, you do. Anvesha?
Yes, ma'am.
You
Agree.
do.
Yeah.
Okay. So now let's ask Sikandar. You agree?
Yes, ma'am.
You do. There was a little, oh, yes, ma'am. So is there anything that you don't agree with?
Ma'am, I recall that it's now they are researching about the polyclonal thing, that it's not monoclonal.
Polyclonal. Acha. So all neoplasms are not necessarily, come from one cell. Is that what you are
Yes.
referring to?
Yes,
All
ma'am.
right, Sikandar, I think that's a good observation, and we will discuss that. Okay. So what about Ashrita?
Ma'am, I agree, ma'am, but the
Agree?
heritable changes,
You agree
could
with
be
or
ac-
you don't agree with the heritable changes?
it could be acquired also, ma'am.
Oh, sure, but this heredity is not from your getting it from your father or your mother. This is one cell to the next cell. Okay, everything. How does the liver become the liver, etc. Okay,
By
because
division.
it's inheriting, no, the changes from the stem cell, which then gives rise to daughter cells, and then they do it. So that's the heritable changes that they are talking about. Okay?
Okay.
So once you have got a cancer cell, its progeny will inherit all the changes that have made that into a cancer cell. Now, do you have any issues, Ashrita?
No, ma'am.
Yes or no?
No, no, ma'am.
Oh, okay. So, Tejas,
I'm
you
having
agree?
some. No, ma'am. Not
Huh.
only the heritable changes, some changes like lifestyle changes. In today's world, there are many stressors in life, and there are researches going on there which says that some stressors also leads to cancer.
Well, this is not about that. No, we just talked about it. It is what Ashrita asked before. It is not about what you inherit from your parents or whatever. Once a cancer cell has been formed, its progeny, the whole clone will inherit what this cancer cell actually starts out with. Do you have
Yes.
any problem with that, Tejas?
No, ma'am.
No, ma'am. Okay. Ujwal?
Ma'am, I don't completely agree with it
All right. So tell me what you don't agree with.
because I feel, ma'am, the definition doesn't cover the hallmarks. It's just partly covering the hallmarks of
It
cancer.
doesn't cover the hallmarks. You
Partly.
first, no, I'll tell you, you see, if you have to define anything, you cannot say everything about it, right? Once you have a neoplasm, and if that neoplasm is a cancer, because the hallmarks do not apply to benign lesions. Do you realize that, Ujjwal?
Yes,
It
ma'am.
cannot apply to benign lesions. Okay, so the hallmarks have to apply to malignant neoplasms. Okay, and you cannot put everything into a definition. It has to be something that you say in one or two lines, normally one line, that means one sentence, which defines the thing that you're trying to define. And then you can expand on that definition and say that if, for instance, you're defining a human being, then you will say a human being has this narrow sort of definition. And then you will say, oh, there are human beings that have curly hair and those that have blue eyes and those. Now, you cannot possibly have all of that in the definition, no? So you have a lean, mean definition. Now that I've said that, Ujjwal, do you agree with this definition?
Yes,
Is there
ma'am.
anything else you don't agree with? What? Ujjwal, I can see you.
Yes, ma'am. I agree with it.
Oh, now you agree. Good page.
Ma'am,
You agree?
this abnormal mass or tissue, it is occurring in which type of cellular
So, but you
organism
disagree
or
with the abnormal mass. Is that what you're saying?
no, ma'am, it is okay, but it is occurring in which type of organisms or
In organisms. Meaning what? Sorry.
um,
Now, it is an
like
abnormal mass of tissue, and it is not just an abnormal mass of tissue. Of course, you have abnormal masses of tissue in all sorts of things, no? An abnormal mass of tissue may be granulation tissue, all right? But then they've added the other parts, the growth of which exceeds, is uncoordinated, that persists. So you can't disagree with abnormal mass of tissue, okay? That has to be there. Otherwise, how would you even know that there was a neoplasm, okay? If there was no mass to actually identify. All right, so Gurtej, I think the rest of it you agree with? All right, has Sumitra answered? I'm not sure. Sumitra?
Noted, ma'am. I agree with the definition, ma'am.
Okay, you agree with this definition. All right, all of you have more or less agreed with the definition. Now let me ask, all right? All of you have seen a uterine leiomyoma?
Yes,
Every one of you?
ma'am.
All right, very good. Now, is a uterine leiomyoma a neoplasm according to this definition? Let's start again. Anis,
Yes, ma'am.
is it according to this definition a neoplasm?
Ma'am, yes, ma'am.
You think so?
Yes, ma'am.
Anybody disagrees with Anis?
Ma'am, under hormonal influence, the size of the neoplasm does change, but it persists even after hormonal cessation.
I see. So what happens to a leiomyoma after menopause?
It will decrease.
Hmm? Does it persist in the same excessive manner after the cessation of the stimuli which evoke the change? Yeah? Anybody knows how we treat a breast cancer with
Hormonal
hormonal
therapy?
therapy? And what happens?
Yes,
Hormonal
ma'am.
therapy is used for debulking, like
Oh, does it? Is that so? Does anybody know? Ujjwal, you are in Tata Hospital, right?
Yes, ma'am.
Yeah. So if you remove the estrogen from the system by doing many things, you can remove the estrogen from the system by doing an oophorectomy. You can remove estrogen from the system by giving anti-estrogens. Yes, Ujjwal?
Yes, ma'am.
What happens to estrogen-dependent tumors? What's the point of giving it? They shrink, right? And they sometimes disappear completely. So now you tell me, never mind about breast cancer, we're just talking about a uterine leiomyoma. Okay, yes, it is an abnormal mass of tissue, and the growth did was excessive and it was uncoordinated. Otherwise, you wouldn't be able to see it as a leiomyoma. All right, it wasn't forming normal uterine muscle. It does resemble uterine muscle, the cells do, but you can still see that it's a tumor, and therefore it is uncoordinated with the growth of its neighboring uterine muscle. But there is no excessive and unregulated proliferation and it is certainly not independent of physiologic regulatory stimuli, because leiomyomas shrink with, with the physiological stimuli that it undergoes. And we know that gynecologists actually tell patients with a leiomyoma, if they are somewhere around menopause, that don't bother about this, okay? The leiomyoma will more or less disappear after you have become menopausal. And this is something that we know. So does this leiomyoma actually fit the definition of a neoplasm? And then you will say, oh, this is the exception to the rule. And it is not the exception to the rule. You know that it is even a cancer undergoes disappears under physiologic neoplasm, physiological removal of the stimuli, yes. And there you said it persists in the same excessive manner. It does not. After the cessation of the stimuli, you remove estrogen from the system, and here we have Rini M. Rini M, again, you have pressed that. If you want to ask a question, then please don't ask for annotation, or you're doing this by mistake by pressing that little thing which I said you should not do. Okay, I'm going to decline this. Okay, fine. So obviously, there are parts of this definition that do not apply to a majority of benign tumors. Yeah, even fibroadenomas shrink. Fibroadenomas actually become hyalinized and some of them actually disappear. Okay, so you get certainly to all many benign neoplasms. Okay, is there anything else that we need to worry about? Now I'll ask you. Okay, tell me this. What about an extra thumb? Gurtej, is an extra thumb a neoplasm?
No.
Gurtej, you're there, right?
Yes, ma'am.
So is it a neoplasm? Go one by one.
No.
Is it an abnormal mass of tissue? Is it abnormal? Is it a mass of tissue, and is it abnormal, Gurtej? Because you said something about abnormal mass of tissue. That's why I'm asking you. Gurtej, is it an abnormal mass of tissue? An extra thumb?
Ma'am, it should not be there, but
But
it is
it's
not
there,
abnormal.
right? Ah, there you are. Did its growth exceed, was it uncoordinated with the rest of the thumbs and the fingers and all? Yes or no? Just like a leiomyoma, right? It was uncoordinated with its normal uterine muscle. So was it supposed to be there, and it's not there, and it's there, right?
Yes, ma'am.
Right? Ah, very good. Did it persist, the thumb?
Yes, ma'am.
Oh, yes, it did. Okay. After the cessation of the stimuli which evoked the change. So now tell me why this is not a neoplasm, Gurtej? Why isn't it a neoplasm? Problem, no, Gurtej?
Yes, ma'am.
Yes.
May I take this?
Yes. Yeah, who's that?
Anvesha, ma'am.
Come on, Anvesha.
Ma'am, there is no unregulated proliferation post the formation of that thumb.
Mhm.
It is just persistent. It doesn't grow
So
beyond.
then the same reason you didn't give the same pass to the uterine leiomyoma.
But ma'am, leiomyoma may grow if there are estrogen
I mean,
circulating.
it may not. You cannot decide, no, for the leiomyoma, Anvesha.
Yes, ma'am.
Ah, so you gave a pass to the uterine leiomyoma, but you're not willing to give that same pass to the extra thumb. All right, come on, let's start from the beginning. Anis,
Yes, ma'am.
Why is an extra thumb not a neoplasm? And I think we have to understand this. Then, all this hallmarks and this and that. Come on, why is an extra thumb not a neoplasm?
The clonality, maybe.
Clonality. So it's not clonal. Good thing. Anis, are you clonal? Of course you are.
Yes, ma'am, I am.
Every single cell in your body has the same genome as every other cell. And you're telling me that every cell in that extra thumb does not have the same genome? Huh?
It has, ma'am.
It
But
has.
then
So
the
what?
then the proliferation that happens,
So
considering
it did
uterine leioma.
proliferate, otherwise you couldn't get an extra thumb, no?
But then the uterine leioma can transform into a.
Oh, I see. And an extra thumb cannot. You mean you cannot get a cancer in an extra thumb, huh?
Yes, ma'am.
This
Yes,
is
ma'am.
wonderful.
Yes.
Anis. All
But
right,
then-
Ujjwal, you're at Tata Hospital. Tell me why an extra thumb is not a neoplasm. Somebody will have to be able to look or think. Yes, Ujjwal.
Ma'am, Tejas.
Come on, where are you?
Ma'am, Tejas, can I speak?
Oh, Tejas. Yes, of course, Tejas. Yes, he's passed his MD.
Ma'am, I don't know whether I'm right or not, but I will try. The extra thumb, which is there in any patient, in any person, it's normal to him.
It's normal to him.
Maybe
So then
It may-
why don't I say that so many people have got leiomyomas? A fibroid is a very common thing. So it's normal to those people, no? Huh? In fact, extra thumbs are much rarer than all the leiomyomas and the fibroadenomas, etc.
Yes, ma'am.
Hey, come on, you guys.
Yeah,
Can
but-
you not see the difference?
Ma'am, embryonic developmental anomaly, like it happens.
Embryonic developmental anomaly. So now, who was that? Anvesha?
Yes,
Who was
ma'am.
it?
It's-
Anvesha. So what happens if you get, congenital neuroblastoma? What do you want to call it?
Neoplasm.
Why? It was there, no? The child was born with it. So now don't bring embryology into this story, okay? And the answer is very simple, no? When I look at that thumb, does it look like a thumb?
No.
No, it doesn't look like a thumb. The thumb doesn't look like a
Normal thumb. Normal. Like
Well, it looks like a thumb, no? Doesn't it have skin on the outside? It has a nail. Then it has the subcutaneous tissue. Then it has muscles inside. Does it or does it not look like a thumb? Yes or no?
Yes.
Yes, ma'am. All right, very good. In other words, it is organized exactly like a normal thumb, which a leiomyoma is not. It is not organized like normal uterine muscle. Yes or no? Yes. So when I see a thumb and an extra thumb, I have good tissue organization. Now that is not reflected in this definition, okay? And that is something that we should think about. People talk about excessive growth and it goes on in an unregulated way and it is independent of physiologic regulatory stimuli, but we do not really think about something very important, and that is tissue organization. This is lost in all neoplasia, however benign that neoplasm is. And sometimes people say, oh, but what about a hamartoma? But let me tell you that a hamartoma is just another kind of benign neoplasm. Okay, there are all kinds of definitions of hamartomas, but for all practical purposes, it is actually another kind, and people who have bothered to test have also found that hamartomas are clonal. Okay, so I think let us at least accept that this definition of a neoplasm, please you learn it by heart. If you're asked in the exam, please say this. But in your mind, you have to understand that it does not cover everything that may be seen in neoplasia, and not just exceptions to the rule, because every definition might have an exception to the rule. But here, this is not the this definition does not even obey the rule and its own rule. All right, so yes, we agree that there is uncoordinated proliferation, okay, which is also present in an extra thumb. But what the extra thumb does not have is disordered tissue organization. And however benign a neoplasm is, including a lipoma, you are able to see that it is a lipoma because it has not organized itself like normal adipose tissue. Okay, so there's disordered tissue organization. I say that it is often clonal. Yeah, and you know what clonality is. It's a process that affects one type of cell and which can be traced to one progenitor cell. And see, I have used the word often over here because, like somebody said, and I can't remember who it was. I think perhaps it was Sikandar. Were you the guy who said that? No, I don't know whether or Tejas, I can't remember who, but you said that things could be not always clonal, they could be polyclonal. I think it was Sikandar who said that there is research saying that things may have more than one clone. Very good, Sikandar. So yes, the majority of neoplasms have just one type of cell, and all of the clone can be traced back to one progenitor cell. Now, having said this, I'm going to ask somebody, since it is clonal, yeah, Sumita?
Yes, ma'am.
Yeah, can you answer this question? Can an amoeba get a neoplasm?
Yes, ma'am.
All right, so Sumita says that an amoeba can get a neoplasm. Anybody disagrees with Sumita? Sumita, is your name
It will occur
Sumita
in
or Sumita?
multicellular organisms.
Sumita.
Sumita. Yeah, who disagrees with Sumita?
And it will occur in multicellular organisms.
Yeah, somebody was answering. I know that Anvesha wants to answer, but I heard a male voice. Who is disagreeing?
Ma'am.
Yes, Ujjwal or Gurtej? Are very good, Gurtej. Tell me, why do you disagree with Sumita?
It will occur in multicellular organism. Amoeba is
It will occur. What will occur in multicellular organism?
neoplasm.
Neoplasm. Why can't we get it in an amoeba? Will you please explain that to Sumita? After all, this is a clonal process, no? So why does it occur in? Do you think, Gurtej, that it can only occur in multicellular organism? Explain to Sumita. You say that it occurs. Yes, of course, neoplasia occurs in multicellular organisms. You and I are multicellular organisms and we have neoplasia. Rats have neoplasia, yes. And there are plants that have a neoplasia. Yeah, they're all multicellular. But can an amoeba get it?
Amoeba is unicellular.
It will occur where an organized tissue is formed.
That is absolutely right. If you don't have tissue, you cannot get neoplasm. And Gurtej, you're absolutely right. Because if one amoeba splits and becomes two, it doesn't stay together, right? What happens? There are two amoebae. Yeah. So even if one amoeba has a mutation, then its daughter cells will have the mutation. They will become two amoebae. They cannot form a neoplasm because a neoplasm means that there is a growth and a growth of cells. And we have already said here that that growth, yes, is uncoordinated. It is often clonal, that's true, but that has disordered tissue organization and no amoeba has tissue. Yes, Sumita, did you understand that?
Yes, ma'am. Yes, ma'am.
You know that a unicellular organism does not have tissue, okay?
Okay,
So
ma'am.
it can only happen in a multicellular organism, and that too, the higher orders of multicellular organisms, yeah, that form tissues. Now, if I have a sponge, for instance, okay, a sponge is a multicellular organism, but it doesn't form tissue. Okay, it doesn't have blood vessels. It doesn't, it's just a mass of cells that stick together. So it's an extremely unlikely situation that in some multicellular organism without tissue organization that you will get a neoplasm. Now, are there any questions in the chat box about this before I go on to the next thing? Shrutika or Sindhura, is there anything in the chat
Ma'am,
box?
there are no specific questions, but the answers to the questions you've been asking to students on similar
There's one. Sure. There's one. Can developmental anomaly be compared to neoplasm?
No, of course not. Developmental anomalies, like they are developmental anomalies, but they are organized like tissue. So an extra lobe, okay, in the thyroid, remnants of things that had happened in the past. That means if you have, say, mesonephric remnants, at one time they were fully differentiated. Yes, you recognize them. That are differentiated for that particular stage of embryologic life. So it cannot be considered to be a neoplasm. I think we dealt with that when we dealt with the extra hum. All right, good. So if I had to define a neoplasm, how do I define it? It's an abnormal, often clonal, cellular proliferation that exhibits uncoordinated growth and disorderly differentiation, because that is what tissue organization is all about in a multicellular organism. Do people feel that this is worth considering as a yes? So all I'm doing is giving you a definition. Tejas doesn't have to remember this, or he may remember it, because he's already passed. There's no examiner who's going to ask him to define a neoplasm. But the rest of you still have to know what a neoplasm is. And for God's sake, don't give this definition, because your examiner, who has not thought about it, will probably not accept this definition. I'm giving it to you so that you understand what neoplasia is. Okay, so now that I've said this, who wants to take this question? What is differentiation? Because we say this all the time. This is well differentiated, poorly differentiation. This has lost its differentiation. So who would like to take this this question? Ashrita? Oh, everybody's asking, but Ashrita hasn't spoken for a long time.
Yes, ma'am.
Ashrita, what is differentiation?
That the cell can functionally develop into that thing.
It is what? Cell?
Cell can functionally able to produce that thing. We can identify the cell like
Produce that thing. All right. Some people wanted to answer. Who was that? Anvesha.
Aishwarya.
Aishwarya. Yes, Aishwarya. Come on.
How close the neoplastic cell resembles to the parent normal cell.
All right. That is how you say it is well, moderately, or poorly differentiated. But what is differentiation? Yes. Who's this now?
Ma'am, morphologically and functionally close to the parent cell, ma'am.
Okay, so again you're saying this is comparative, okay? But what is differentiation? Are you telling me that lymphocytes, or for that matter your blood cells, erythrocytes do not differentiate, erythroblasts do not differentiate to become red blood cells? Are you now going to talk about differentiation as being functionally and morphologically close to what? A red blood cell is functionally and morphologically close to an erythroblast. But what is it? That is differentiation that is going on. Yes or no, Anis?
Yes, ma'am.
Yes. So what is differentiation? That's what I want to know.
From
And we're
the
using
stem
this
cell,
term all the time, yeah?
like the
The
stem cell.
unspecialized.
Oh, so now we're talking about stem cells, huh? What? Sorry?
The stems
And the
from the stem cell, it gets specialization, ma'am. Like
So it is
how
specialization.
Tissue organization and organ towards organ formation.
If you haven't thought about it before, differentiation is this. Whenever you see Asian, it means that we are talking about a process. Okay? Coagulation. Yes? We have the term or not. So it has to be a process. And this is the process of acquiring the features and functions of maturity by cells or tissues. So you may have something that is less differentiated and something that is fully differentiated, okay? And the process by which this particular cell goes through the different stages before it becomes fully mature, that is the process of differentiation. Yeah, now do you understand what that is all about? Excellent. Okay, so if that's the case, now we know what this is all about. When something is completely lacks differentiation, we refer to this as anaplasia. Okay, that means it has no characteristics at all. So when I look at it, I do not know what this particular group of cells is all about. Okay, so it is completely lacking features of any kind. So I don't know where it is going to end up. Now you can have anaplasia that is either monomorphic or it is pleomorphic. Okay, now you see pleomorphic over there. And pleomorphism is what people use this term very loosely all the time. There is mild pleomorphism. No, there is no such thing as mild and moderate pleomorphism. I see it being used all the time. Something that is pleomorphic is markedly varying in size and shape of the cytoplasm and the nuclei. That is what is pleomorphic. Okay? So when something is so varying in size and shape, and when you look at it, unless now you go to actually do some kind of immunohistochemistry that tells you what the lineage is, but when you look at it, it is completely lacking features of differentiation. Then you go to find out, is it showing smooth muscle and markers, and we call it a pleomorphic leiomyosarcoma or liposarcoma or whatever else. But that means a lot of very in-depth study by ancillary techniques. On the other hand, you have something like this on the left-hand side, okay? And it could be almost anything. And it's very monomorphic. You can see that they're all small cells. Now that is also anaplasia because it is complete lack of differentiation. And in this case, this is, what is this now? This is a small cell carcinoma. Okay? It could be a small cell carcinoma. This one is obviously a small cell carcinoma, but something like a Ewing's tumor. All right, it's Ewing's. We've given it a name. We know that it will express these characters. Before we had immunohistochemistry, we knew that it occurred in the bone and it occurred in the soft tissues. And we gave it a name because it was not a lymphoma, it was not a small cell carcinoma, etc. But it is an undifferentiated tumor. So do you understand what you can use these terms, undifferentiated tumor, or you can use the term anaplasia. Today, by and large, the word anaplasia is not used for monomorphic tumors. It is used essentially for highly pleomorphic tumors with marked variation in size and shape of the cytoplasm. Anybody over there can quickly give me one example of an anaplastic tumor?
ALCL, ma'am.
ALCL. All right. Okay, anybody else now? AL cell is a lymphoma, and yes, it was called that anaplastic, but because it had marked variation.
Anaplastic carcinoma of thyroid can.
Very good. So you get an anaplastic carcinoma of the thyroid. You'd never know that it was a thyroid carcinoma. It looks like a sarcoma, but yes, we know that it arises in the thyroid, and we know that we know the way that it loses its differentiation. It starts from either a follicular or a papillary carcinoma, which show you good differentiation, moves through a poorly differentiated carcinoma, and finally it becomes totally anaplastic. Excellent. So now I think we can go to the next thing, and this is very obvious, right? What is a cancer? It's a malignant neoplasm. I don't need to ask you that. But here we are at this, and I'm an oncopathologist, and all of you have seen a lot of malignant tumors. How do we know that a tumor is malignant? Come on, Anis.
For that, then we come to the hallmarks of
Sorry,
cancer.
how do we know that a tumor is malignant?
We look for just like
look for the features. So what features are you looking for, Anis?
We'll be looking for whether there's any invasion or not, ma'am.
Whether there is invasion or not, right? Very good. Right. What about in cytology? Can you tell whether there is invasion in cytology, Anis?
No, ma'am, no.
No, ma'am.
Then
What do we look for?
Then we look for the nuclear pleomorphism. Then
nuclear pleomorphism, all right. So in other words, you're saying that there are cytological features that tell you that something is malignant. Do you think that that's a
yes, ma'am.
Yes, okay. Sikandar, you agree?
Ma'am, just cytological features can help on that.
Cytological features can help. But how do we know for certain that something is a malignant neoplasm? Who else would like to attempt this? Ashita?
Pleomorphism, ma'am.
Pleomorphism. Achha. So you are looking for cytological features. So it has to look like it is a malignant neoplasm.
Yes, ma'am.
All right, Aishwarya?
Gross also we can identify. It's not well
gross you can
encapsulated.
identify it. Okay. All right.
Clinical history also, like rapid growth.
Clinical history. All right. Ujjwal?
Ma'am, we can look for pleomorphism, then NC.
That's what you said. All right. Good page. Somebody else said that. Good page.
Cytology, morphology, and how the
atypical mitosis
tumor behaves.
Atypical mitosis. Achha. Okay. You know, folks, malignant neoplasm is not by how it looks, it is how it behaves. Please remember that. Okay? A tumor may look completely innocuous, and still we call it malignant. Okay? Can anybody give me an example of that? So, malignancy is judged by behavior, not by appearance alone. And Anis was right. One of those behaviors is invasion. The other one is metastasis. Okay? So you might ask me, how do I know by looking at this that it's going to invade or it is going to metastasize? You cannot know. You have learned this by other people's experience. Okay? So I did not go into pathology and discover everything for myself to say that this thing that looks innocuous, like a papillary carcinoma of the thyroid, okay? Show me what are the features in a papillary thyroid carcinoma that actually look malignant. Nothing. They don't have mitoses, yeah? And let me tell you, there are some even more malignant tumors that don't have mitoses. On the other hand, I've shown you two things over here. The ugliest malignant looking tissues is trophoblast. You know that, okay? And it's full of, giant cells and, pleomorphism and multinucleated cells with very dark and hyperchromatic nuclei. all sorts of things. And yet, that is normal. It is not malignant. So, malignancy is as, or cancer is as cancer does. It has had to have demonstrated in the past, maybe, and people have noted this, that this looks, it doesn't have all the features of cancer. Take neuroendocrine tumors. All right, neuroendocrine tumors, carcinoid tumors, do they look malignant? They don't have high nuclear cytoplasmic ratio, whatever it is that you teach your second MBBS students, because many of you probably in your institutions are given the task of taking some lectures with your second MBBS students, and you tell them, no, you draw this chart and you say all the features, they are well circumscribed, they are encapsulated, they are this, they are that. All of that is very relevant. I know that this is a malignant tumor because it has either demonstrated invasion or metastasis. And even in those cases, okay, a mole is invasive and it is not malignant. It might even metastasize to the lung. You know that there are hydatidiform moles that go to the lung, but they are not malignant, okay? It's just the way that these normal tissues or tissues that are benign, this is the way that they behave. So we need to know that what is the behavior, that A, it is a tumor, B, that it is a malignant tumor because it has demonstrated invasion and metastasis. Okay, so don't go only by appearance. So this tells you something else. Okay, and I mean, we are all pathologists. So how do we make diagnoses of cancer? The answer is simply this, that we are standing on the shoulders of giants, no? The people who actually studied all this and have put it into the textbooks, they've put it into articles, papers, talked about it, and that is how science progresses. We know what we believed at one time, and now over the years we are finding out that something that we thought might be, we used to think carcinoid tumors were, particularly those that occurred in the appendix, we believe they were absolutely benign. Maybe they still are, unless they get to a particular, they grow to a particular size and they breach the serosa. Then nobody can guarantee that that carcinoid tumor, it looks no different from a tumor that is unlikely to metastasize, but it has shown its capacity to invade, to enter into structures where it should not be, and then you have no choice but to recognize that it is a malignant tumor. What you call it, how you, what kind of differentiation and how you grade it is a completely different matter. Any questions in the chat box about this, please? Or any of you have got any questions about this? Okay, so it's about behavior, and we know about behavior because we were told by people that this is so, and we have observed it, okay, for ourselves. So that is about cancer. Okay, what is it? Now let us come to some other words which we have a lot of problem with. Dysplasia and in situ carcinoma. And I have shown you some pictures here on the right. Okay. Now let's ask somebody. Sumita, would you like to tell me which picture is dysplasia, which picture is carcinoma in situ? You can just tell me there are three pictures. There's one on top, there's one on the bottom, that's left and right.
The one on the bottom right is carcinoma, in situ carcinoma, ma'am.
All right. Of what? Of squamous epithelium, right?
Yes, ma'am. Squamous epithelium.
Okay. Then tell me anything, and what do you want to say about the top?
It looks like
line. There's a little line that is drawn there. Okay.
Yes,
See the line?
yes, ma'am.
All right. Good. I think I better get a pointer that has some. All right. Here. All right, you see the line?
Yes, ma'am.
So what do you think is left of the line and what is right of the line?
And right of the line, there is maturation.
Okay. And left of the line?
Uh,
It is not. Okay.
yes, ma'am.
So there's less, according to you, maturation. All right. And what about this on the left-hand side down here, Sumita?
This one,
Difficult, right?
Yes,
We
ma'am.
know that there is dysplasia, yes?
Yes, ma'am.
Now, is somebody going to call this high-grade dysplasia or carcinoma in situ? But you see these now. So, Sumita, you were able to look at this. So, can you define for me what is dysplasia?
Abnormal cellular morphology, which is not invaded the basement membrane, is dysplasia.
So, what did you say? Abnormal cellular morphology, and not invaded its
Basement membrane.
membrane. So, does it apply only to stratified epithelia, or can you have dysplasia in the endometrium? Can you have dysplasia in the colon? We say, adenoma with mild, moderate, and severe dysplasia.
Loss of polarity.
Loss of polarity. Okay, what is this loss of polarity? Can you tell me? See, I've got pictures here. So for number one, what is dysplasia? Right? Can anybody define dysplasia for me? Sumita has tried. Somebody else wants to try?
Disordered
Who wants
growth.
to try?
Arrangement.
Third
Disorder.
Tell me, Gurtej, you want to try? I
Disorder
heard a male
arrangement.
voice.
altered cell growth.
No, somebody I can't find out who it is. Who is it, Tejas?
Disordered arrangement.
Well, let's not waste much time. We all need to know how to define things, okay? And we can't put everything into this mix. This is what dysplasia actually is, okay? I wouldn't look here and there for a definition. It's so obvious. You don't get dysplasia in lymphoid tissues. You don't get dysplasia in mesenchymal tissues. You get dysplasia in epithelia. Okay, and it doesn't matter whether this is glandular or it is stratified. So, what is dysplasia? And if you have understood once again the definition of neoplasia, do you or do you not believe that dysplasia is neoplastic? Is it neoplastic or not? Gurtej, is dysplasia neoplastic?
No, ma'am.
No, ma'am. All right, very good. Tejas, is dysplasia neoplastic? Tejas has disappeared. Okay. He's tired. He just went for an interview. Yes, Ujwal, is dysplasia neoplastic?
No, ma'am.
No, ma'am. All right. I can see Ashrita. Ashrita, is dysplasia neoplastic?
No, ma'am.
No, ma'am. Sumita?
No, ma'am.
No, ma'am. What about Aishwarya?
No, ma'am.
No, ma'am. Sikandar?
No, ma'am.
No. Anis?
No, ma'am.
No, ma'am. So, is there a difference then, my dear friends, between CIN, meaning in situ neoplasia, and dysplasia? Are they different things, Sikandar?
Yes, ma'am.
They are. So, in situ neoplasia is different from dysplasia. Yes?
Yes, ma'am.
Oh, really? What about you, Anis?
Yes, ma'am. It is different.
It is different. So, will you explain to me the difference
Ma'am,
between in situ neoplasia and dysplasia?
yes, ma'am.
CIN 1, 2, 3, chalo. And dysplasia mild, moderate, and severe. Is it different?
Ma'am, they are like they connect but the thing is, in carcinoma in situ, there is full
I am
thickness
not talking
high-grade
about
dysplasia.
carcinoma in situ. I'm talking about CIN 1, 2, and 3 and dysplasia mild, moderate, severe, stroke, carcinoma in situ. Because we know that. Yeah? Dysplasia severe dysplasia is also carcinoma in situ. So,
Yes, ma'am.
yes, so now you told me that, Anis, a little while ago, that dysplasia is not neoplasia. But do you think that CIN 1 means low grade dysplasia, CIN 2 is moderate dysplasia, and CIN 3 is carcinoma in situ or severe dysplasia? Do you believe that or you don't?
I believe that, ma'am.
So then why did you say that dysplasia is not neoplasia? It's the same thing, except that it is
It's
not
not breaching,
it is not
invading.
invasive, okay, but it is neoplastic. And if you remember, what is the definition of neoplasia? What is the definition? He may not be there. Come on, Ujjwal, what was the definition of neoplasia? You wrote it down. I know that. What is it?
Ma'am,
You haven't written it down. I know that Ashweta has written it down. Yes, Ashweta?
Yes, ma'am.
So now, tell me, read loudly, what is the definition of neoplasia?
An abnormal mass of tissue,
Mhm.
the growth of which exceeds and is uncontrolled, and that of normal
Uncontrolled.
tissues.
Did I say that was the
Uncoordinated.
definition of neoplasia?
Uncoordinated, ma'am.
What was
Un-
our definition of neoplasia, Ashweta?
An abnormal, often clonal, cellular proliferation
Hmm?
that exhibits uncoordinated growth and disorderly differentiation
Yes.
in a multicellular organism.
Now, so do you think that it fits this or it doesn't fit it?
It fits, ma'am.
It fits. Exactly, it fits. So it is progressive lack of differentiation in epithelia. And what it says is that this is not invasive. That's what it is. You see the grades of structure, architectural disorganization, grades of atypical cytomorphology, and graded abnormalities of differentiation. So dysplasia means, and this can happen in glandular epithelia, in stratified epithelia, but there is no invasion. In glandular epithelia, an example is an adenoma. An adenoma, all adenomas have dysplasia. Okay, it's either mild or moderate or severe. So that is what is dysplasia. And okay, we'll come in the next thing to see what it is. Carcinoma in situ is complete lack of differentiation without invasion. All right. All dysplasia does not show invasion. Carcinoma in situ, in particular, you have to make certain to say that there is no invasion. And all the grades you can see over here in this picture, this happens to be from a larynx. It's not from the cervix. So this is laryngeal dysplasia. This one on the right of that line is showing you mild dysplasia. On the left of the line, you might say moderate dysplasia. Here, this is high-grade dysplasia and you have problems. Should I call it severe dysplasia or carcinoma in situ? Doesn't make a difference at all because they're more or less the same. And here you have severe, carcinoma in situ, but there is no invasion. Anybody have a problem? Are there any questions in the chat box? People just don't know how to even define dysplasia. Okay. And what is the meaning of disorderly growth? And that's where all this story of, and we said it is grades of architectural disorganization. So what do you mean by architectural disorganization? Take squamous epithelium. What? What do you mean by architectural disorganization? We understand atypical cytomorphology and you can see it. Okay, the cells are larger, there is cytoplasmic, the nuclear cytoplasmic ratio is altered. You also see some abnormal looking nuclei, they show you crinkling, whatever else, okay? But what do you mean by grades of architectural disorganization? Anybody wants to answer that question? Yes, Anis?
Ma'am, especially if you take it as squamous epithelium, ma'am. the cells are arranged in an orderly manner. They're in layers, ma'am. Actually, if you see here.
I know this is what somebody mentioned, and I think it was Ashrita. She said lack
then
of
there is
polarity. Okay.
yes, ma'am.
Yes.
So
So
there is
altered
haphazard arrangement of
polarity. Now see this picture down here. It's there in all. Okay. But you see it very clearly on this left-hand side picture. Okay. All the cells in a normal epithelium should be, the basal layer should be perpendicular to the basement membrane.
yes, ma'am.
Yes. And above that, they should flatten, all the cells should flatten, and then they become parallel to the basement membrane. That is normal polarity, because polar means in respect of something. So, in respect of the basement membrane, this is how we find normal architectural organization. Now, we said that neoplasia, in one way or the other, and the more severe it is, the more likely it is to be malignant, is you get severe disorganization, architectural disorganization, and now you can see it. Do you think all of these are placed nicely parallelly? Some are, placed at angles, etc., etc., and of course you see atypical cytomorphology. So, this can not be called normal, and this is what is called lack of polarity. Has anybody got any questions on that, please? And if it's in the chat box, please let me know.
Yes, ma'am.
Before
This one is poorly differentiated and dedifferentiation similar.
poorly differentiation and dedifferentiation is both of them have got poor differentiation, but dedifferentiation assumes that once upon a time that tumor had better differentiation, okay, and now that differentiation is lost. It is now losing its differentiation. So say I had pleomorphic adenoma and I knew it looks very benign and everything else, then it dedifferentiates to a carcinoma, or I have a nice well-differentiated chondroid tumor, which you can see the hyaline cartilage and everything, and then suddenly it goes wild. Now you might ask, why or how does it dedifferentiate? Now I don't think that a fully differentiated cell is able to go back. So it is a tumor. There are stem cells in that tumor, and those stem cells are differentiating beautifully, all right, into the fully mature form. And for all practical purposes, that was benign. And then what happens, those stem cells, something happens to them, either they acquire a mutation or there is a change in the environment in which those tumors are growing. And you know that can happen if, for instance, we have a better or less well-differentiated tumor that is given radiation therapy, okay? And that can convert a nice, well-differentiated tumor when it recurs into a very high-grade tumor. So the stem cells there have had something, that a switch in their genome that makes them less susceptible to the differentiating influences that are coming to that tumor. Is that all right? Has somebody understood that? We can discuss it again if
Yes, ma'am. So as an extension to that, is dedifferentiated same as undifferentiated? Is another question.
Yes, it is. No, then it becomes undifferentiated. Of course. But we know that it was well differentiated, and therefore we call it dedifferentiated. If you never knew that there was a well differentiated tumor, then you call it undifferentiated. It's as simple as that. Okay.
Right. And
so there are some that come that are undifferentiated de novo, and we know those tumors. Some of them we talked about, and you know that we call the anaplastic thyroid carcinomas. We gave that example. Yes, it starts out as being well differentiated, follicular or papillary, goes through a poorly differentiated, and then it becomes totally undifferentiated and anaplastic. And when you see this patient at the last stage, you may not be able to see the original well-differentiated tumor from which it arose. All right? Very good.
One more question. What is the difference between high-grade dysplasia and carcinoma in situ?
There is none. It's the same thing. Okay, so
that's all, ma'am.
yeah, all right, very good. So now this is what this is, okay? And now we have terminology. And that's what I was asking you. The terminology for dysplasia and carcinoma in situ could be in situ neoplasia, and you can have cervical in situ neoplasia, you can have vulval in situ neoplasia, in which you call it VIN. In the endometrium, you call it EIN, that is endometrial intraepithelial neoplasia, you say, or atypical hyperplasia. Some people call it atypical hyperplasia, okay? And then there is this term EIC, which is endometrial in situ carcinoma. That is used for the serous type of intraepithelial neoplasia, whereas EIN is used for the endometrioid. I don't want to sort of split hairs here, because most of you may not even have heard of serous carcinomas of the endometrium. Okay. Then in the breast, you say atypical ductal hyperplasia and you say duct carcinoma in situ. There is absolutely no histological difference between the two. Okay. If you have low-grade DCIS and ADH, it is only the extent. So if you have a larger extent of tumor, you call it low-grade DCIS, otherwise you call it atypical ductal hyperplasia. So you're getting the idea that pathologists are now splitting hair, okay? And so you have DCIS of low, intermediate, high. And I just told you that adenomas in the colon, in the stomach, etc., are graded with low, moderate, and high-grade dysplasia. So now all my 9 students over here, do you agree that dysplasia is neoplasia? Is it? Do you agree or you don't?
Yes, ma'am.
Yes. So all of you said no, but I'm glad that you have understood this. All right. Now, I'm going to ask, this is now cervix. Okay. So who has done cytology? Because some of you who have done in the first year have not done cytology. So Ashweta, have you done cytology?
Yes, ma'am.
You've done?
Yes, ma'am.
Which
Yes,
year are you in? 18 months you've done?
14, ma'am. I'm in the 14th.
14 months. So did you go through cytology? You
Yes,
see
ma'am.
pap smears? You have?
Yes, ma'am. I have seen.
So maybe you can answer this question. Okay, who's that now? Was it Ashrita or was it Anvesha? Ashrita, yes. All right, tell me. This is CIN, this is normal, okay? This is CIN1, this is CIN2, and this is CIN3. All right, is the diagnosis of 1, 2, and 3 possible on a pap smear? The answer is simply yes or no.
No, ma'am.
No, ma'am. All right. Anvesha?
Ma'am, possible.
Possible. Okay. Aishwarya?
Ma'am, like counterparts can be given, not the exact diagnosis in 1, 2, and
Fine, but it's the diagnosis of CIN 1, 2, and 3. You'll call it LCIL and HCIL. Doesn't matter. So let me say LCIL. Is the diagnosis of LCIL possible by pap smear?
Yes, ma'am.
Yes, it is. So
Yes,
in
ma'am.
other words, you're telling me that CIN1 can be made, right? The diagnosis?
Yes, ma'am.
Excellent. Sumita, is it possible?
Yes, ma'am.
All right. Tejas?
Yes, ma'am.
Oh, okay. Ujjwal?
Yes, ma'am.
Excellent. So all of you said, and the answer is absolutely right. Has the chat box said it is yes? Yeah, because everybody will make the diagnosis, right? But now I want to know, you see the difference over here? You know, who all of you will tell me what is CIN1 and how do you differentiate it from CIN2 and from CIN3? Will somebody tell me on histology? And I've got the pictures for you here. How do you differentiate that?
The extent of dysplasia.
This extent of dysplasia, what do you mean by that, Ashrita?
The full thickness, or it is
full thickness, okay? That is CIN3, right?
Yes, ma'am.
Excellent. Then
in the
that is
CIN1
full
it will be
thickness. So that means the
less than
whole
1/3.
polyepithelium. Then So what about CIN2? Come on, Ashrita.
Ma'am, if it is less than 1/3 of the thickness, we call like SIN1.
SIN1. So here, less than 1/3, it is SIN1 in this big picture. And then
If it is more
2/3,
than one,
it is, which you see over here. It is
it is
CIN2,
SIN2.
right? Excellent. And this. So now, Ashrita, or any one of you, you're going to tell me, how do we make a diagnosis on pap smear? We take a smear, right? So we take one of these swab sticks, or we take a spatula, and then we take the superficial layers, right?
Yes, ma'am.
Yes, and we smear them, correct?
Yeah, ma'am.
But I heard, Ashrita, just now, you telling me that the abnormality is in the lower 1/3 in CIN1, it is 2/3 in CIN2, and it is full thickness in CIN3. So I will be able to make a diagnosis of CIN3, no? Because the top layers are come out on my smear. So how do I make the diagnosis of CIN1 and 2? What do I do? I scrape like that? No, I don't. So come on, Ashrita, how do I do it? Because you all answered yes.
In PAP, we can give like L-seal and H-seal depending upon the other
Don't
features.
care whether you call it L-sil or H-sil, or you call it CIN1, 2, which CIN1, which is L-sil, and the other two are there. I want to know if the abnormality is in the lower 1/3 or lower 2/3. How do I make the diagnosis on a cytology smear? Because I'm just taking the superficial cells. Yes or no?
Yes.
Oh, very good. So, Anvesha, everybody answered yes, 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 yes. And all the people in the chat box said yes. So now you tell me, I can make the diagnosis of CIN3, that is H-sil.
H-sil.
Because, yeah, there in the top, here I'm scraping away the top, okay? And I'm smearing it, so I can. But now please tell me, how? That's the question I'm asking. The question is how? Yes, Manish.
Ma'am,
That's why I'm showing you, the pictures.
yes,
You
ma'am.
have to imagine.
The based on the presence of the other cytological cells,
What cytological
which
criteria? You tell me, the lower 1/3 or the lower 2/3 is abnormal. So then how do I make this diagnosis on a smear which only gets the superficial cells? Anis, you know my question, no?
Ma'am,
Ah.
we can have like for CIN1 you'll find mature squamous cells also, no, ma'am? Like
You'll find what?
along with those atypical cells, you can have
Along with atypical cells. So you're going to see atypical cells which have come from the bottom. You scraped it so hard. Yes, Anis? Anybody there who wants to answer this question? Anybody in the chat box? See, I know that you guys, that's why I am not asking you to imagine, I am asking you to see. What did we say was the diagnosis of dysplasia? Doesn't matter, you call it H-sil, you call it anything. What is the definition of dysplasia? Yes, Anvesha, she's very good at definitions. Yes. What is it?
Intraepithelial neoplasia, ma'am.
Very good. Intraepithelial neoplasia. So, but what is it? What did we define dysplasia as?
Abnormal site.
Disordered
That's not what we defined it as. Come on, what did we define it as?
ma'am,
Progressive
lack
lack
of
of
differentiation.
Did you say?
Epithelium.
It is progressive lack of differentiation in epithelium. Yes? So what is the meaning of progressive lack of differentiation? What is the meaning? Because you are very good, all of you, at learning by heart all definitions. I'm wanting to understand, do you understand? All right? So, You're seeing this, no? Do you see this over here? Now this is CIN1, yes? And
No.
all of you are telling me that it's the lower 1/3 that is involved. Now, what is the meaning of differentiation or lack of differentiation? Is it only in the lower 1/3? You mean those cells in the lower 1/3 are abnormal and everything above it is absolutely normal? It cannot be, because if you have cells and the stem cells or the parabasal cells that are there at the near the bottom, if they are abnormal, yes, they are obviously going to give rise to progeny, which are also abnormal, yes? And those abnormal cells, if they show you no differentiation at all, they become CIN3. Right. If they show a good deal of differentiation, it means you still get some loss of polarity, you will still get maturation, but that maturation will be arrested at some stage, because it cannot reach the stage of showing you nice superficial cells. So the superficial cells that you see here in the normal will probably get as far as the high intermediates. And those high intermediates will show you the abnormal nuclei. So when Anis was saying, oh, you will see some abnormal cells along with it, what abnormal cells is it that you're seeing? You are seeing, and I will show this to you. Here you can actually see it, that the top layers are not looking like what you should see in normal. They are actually showing you over here in the CIN2, it is showing you abnormal cells at the top. So please don't even think about this ridiculous definition that the lower 1/3 is abnormal, the lower 2/3 are abnormal. What is that abnormality that is in the lower 1/3 and the lower 2/3? Come on, Anis, what is that abnormality? It's an abnormality right throughout the epithelium. But what is that abnormality that all students are talking about when they say lower? What is it?
Pardon, ma'am. Hello.
Yes, yes, Anis.
Progressive.
The differentiation that is.
Oh, so it is the basal layers and the parabasal layers. It looks blue because the differentiation is less and less. So it is most over here. Yes, you have a few layers of basal and parabasal cells, and then it starts to differentiate. And you see how they are flattening, but you still see that the nuclei are all not nice and parallel. Some of them are, sort of placed perpendicular, some obliquely, and I'll show you that. And this is also true over here. You have loss of polarity right throughout the epithelium. So please don't believe that it's only lower 1/3, lower 2/3, or full thickness. This full thickness is complete lack of differentiation. Here there is good differentiation, but it is lagging and you have abnormal nuclei. Over here, you have some degree of differentiation, certainly more than CIN1, but certainly less than CIN2, and you see the undifferentiated basal cells in the lower 2/3, but the rest of it is still differentiating, but it is differentiating abnormally. And I will show you this, okay, in a minute. So the answer is graded disorganization and differentiation, which if you look at high power here, can you see? You can see this in the lower part of the epithelium. You see it's like basal cells that are abnormal and it looks blue. And that's why people say, lower 1/3. There's nothing lower 1/3 about it. The whole thing above that is also showing disorganization, albeit there is some degree, a good degree actually, of differentiation in CIN1, but not more in CIN2. Is there anything? There's more in less in CIN2 and absolutely nothing in CIN3. All right. Anybody in the chat box has any questions on this?
Questions, nahi, ma'am. There are comments that even NC ratio and increase in mitosis is seen in SIN 1, 2, and 3.
Of course it is. It's bound to be, but it is in better differentiated cells. It's not in basal and parabasal cells. You recognize them as being high intermediates or low intermediates, as the case may be. Of course it is going to be, because you have disorganization, you have lacking differentiation. Okay, so that is how you are able to do it. And you see this beautiful differentiation over here. All right, lack of differentiation, which you should only see in the basal layer, is now occupying this the lower 2/3. But above that, there is differentiation. There is increased nucleus cytoplasmic ratio, but in what? Not in basals and parabasals. It's the progeny of these basals and parabasals which are differentiating. Okay, so just like what you would see in a well-differentiated squamous carcinoma, right? You will see that there are pearls and other things being formed. In a moderately differentiated squamous carcinoma, less pearls, etc., are being formed. Keratinization is less. And in a very poorly differentiated carcinoma, you may not see any keratinization at all. And that is exactly what is happening, except that this is in an in situ situation. That's in situ, this is in situ, that's in situ. It is not a carcinoma in situ, which only CIN3 is, but all of this is neoplasia in the epithelium. It's intraepithelial neoplasia. Have you understood this? And if you haven't, we have the next chance in the neoplasia number 2 to go through this. All right, so now we come to the hallmarks of cancer. I'm not terribly excited about hallmarks of cancer because it's not something that you need to understand in great detail. What I just told you before is what you need to understand. Once you know that something is a cancer, yes, there is sustained proliferation. It evades growth suppressors, otherwise it may not grow. So it could be stimulation of growth. It could be evading growth suppressors, because growth is one of the defining features in the definition that we have of cancer, right? There is invasion and metastasis, which we have talked about. Cancers try to attain immortality, and therefore, see these beautiful symbols? You see this infinity, the symbol for infinity. So enabling replicative immortality, angiogenesis, you know about this. Resisting cell death, that means apoptosis doesn't work well in that system because the tumor has learned how to avoid apoptosis. Okay, so these were the 6 hallmarks that the high priests of tumor biology, that's Douglas Hanahan and Robert Weinberg, they published in 2002. And it still is being reproduced in our textbooks, okay? They added some, 10 years later, they added 4 other or hallmarks, okay? 2 are of the cancer cell, meaning that they deregulate cellular energetics. Then you have, they avoid immune destruction. So now you know that there's a lot of therapeutics that tries to prevent this, you know, the immune destruction that the tumor cells are, the killer cells are trying to get rid of the tumor cells, but the tumor cells have their defenses against the cytotoxic T cells, okay? So that's how they avoid immune destruction. Then there is the stroma, or the microenvironment, which promotes inflammation, and the cytokines in that inflammation provide growth factor stimulation to the tumor. You have genomic instability because a number of tumors actually show you, you know, they are very unstable, and they're constantly undergoing problems in the genome, either whole chromosomes, or there is chromosomal instability, or there is genetic instability in which portions of the genome are continuously being broken down and repair is not taking place. All right. So this is the whole thing, which I just said now. I've put all of this. This is, of course, taken from, it's an iconic picture that Robbins has over here. but I have modified it. Okay, anybody wishes to take some kind of screenshots, you may do it. And I love the pictures because they've managed to show very well by symbols everything that we talked about now. All right. I just want to tell you in short something about autophagy and something about anoikis, because these are words that are in many textbooks and people don't understand them. The Warburg effect is about what they mean by cellular energetics is our normal respiration that in normal cells is through the mitochondria, okay, which is oxidative phosphorylation. But what happens in many tumors is that is bypassed, and tumors use what is called the glycolytic pathway. Now that is a very inefficient form of energy. It is also requires a huge amount of glucose that has to be taken up by the tumor because its energy consumption is around glucose. So you should not feel surprised that somebody who has a tumor, or for that matter, somebody who's diabetic, starts to lose weight because the tumor is literally catabolizing all the sources of glucose that are present, that's cancers by and large, I'm talking about, that are present in the stores. So that is what is called the Warburg effect. Now, any one of you can tell me where in our diagnostic armamentarium, and I don't only mean pathology, we use this Warburg effect to
PET scan.
PET scan.
in what? In a PET scan?
Yes, ma'am.
In a PET scan. What PET scan? What PET scan are we talking about? Huh? Aishwarya? What is this? What is a PET scan? What is PET? Positron emission tomography. So what kind of PET scans can you have? It's a metabolic scan. Yeah. So by itself, it tells you nothing. It is when the PET scan is superimposed on a CT that you know what is actually happening and what is being metabolized. So what is being metabolized? What is that PET scan? Oh, there are types and types of PET scan, all right? The common one that is done is known as FDG PET. So what is FDG PET?
Fluorodeoxyglucose.
Yes. So what is done in that? Who answered that question? I don't see all your faces here, so I don't know. Who answered the question? It was a big voice. Huh?
Anees, ma'am.
It's us. Sikandar. Who?
Yes,
You answer the question, Sikandar?
by my side, yeah, fluorodeoxyglucose.
Okay, very good. But what do you do in a PET scan?
Ma'am, we inject the radioactive glucose.
Absolutely, that's right. And you inject that, and because any tissues that are avidly taking up glucose, yeah, normal tissues that avidly take up glucose are the brain, because the brain is very greedy for glucose, and that's why you feel lightheaded if you don't have glucose in your system, right? If you're hypoglycemic, you start to faint. Okay, because the brain needs a lot of glucose. So normally, yes, there are tissues that take up a lot of glucose, but apart from that, it's inflammation and it is tumors. Okay, so tuberculosis will take up FDG PET, very inflamed tissues, or if a child is crying and its thoracic muscles are going to take up a lot of glucose, because when you're using your muscles take up glucose, you know that, no? An athlete who's running, etc. And when it's happening, if you're just at rest, your muscles are not taking up glucose. But if you're using them, then you overuse them, then you get lactic acid that comes out of this glycolytic pathway. All right, very good. So let's quickly go through this. Yeah. Hallmark number 1 is proliferation. And that is regulated by growth factors, cell surface receptors for those growth factors, and downstream signaling through kinases, all right? And all of these, the growth factors, the proteins that we call growth factors, the proteins that we call cell surface receptors, and the kinases. And please remember, these are all proteins, okay? Are coded for by these genes, which are called oncogenes, because they happen to be involved in, in tumor production and tumor progression, okay? You also have paracrine mechanisms. What is paracrine means? That the cell secretes growth factors, which then act on the cell itself. So it is a continuous process of a self-stimulation by paracrine mechanisms or by cells that are close by to the cell. So there you can have those kind of mechanisms. You have actimate. How do these growth factors, whether they happen to be cell surface receptors, kinases, or actual growth factors, they often have mutations in the genes, which are known as activating mutations, okay? And there is this very interesting phenomenon that under normal circumstances, if something is proliferating a lot, then, the cell actually pushes this, the mechanisms within the cell push the cell into, death, that is by apoptosis or senescence. This is, and yet, tumors have learned how to evade this process. Now, all of you should have heard of receptor tyrosine kinases. They are very, very important now. What are they? They are tyrosine, they have a tyrosine residue that is within the cell. They have an extra cellular kind of structure, which when there is a ligand, the ligand is something that comes, it's like a key that gets into the lock. When a ligand comes to the cell membrane, these receptors dimerize. That means they are sitting by themselves, they come together. And like I will show you in the next particular slide, it's like how cricketers on the field or fielders are taught how to hop a ball. No, they are supposed to put their hands together and open their palms, and the ball is supposed to float into their hands. And that is exactly what our receptors do. So when this tyrosine is phosphorylated, this transfers the phosphorus molecule to its substrate, and the substrate then, with downstream signaling, gives rise to a cellular response. And you should be familiar with these tyrosine kinase receptors. Can any one of you tell me the names of any of these tyrosine kinase receptors? They're known as
IGFR.
EGFR, excellent. Anything else?
Yes,
common things that we know. EGFR, KIT, PDGFR. Yes, very good. RET, which is involved in what? RET involved in medullary carcinoma, thyroid. Yes, and
N2.
yes, and also in papillary carcinoma of the thyroid, as well as in MEN2. Then you have VGFR, all right, which is involved in renal cell tumors. You have FGF and all of these. All receptor tyrosine kinases, and they are also considered as part of this whole growth factor system, which in this case we call oncogenes. Okay, so all of these are listed as oncogenes. Okay, sorry, annotation I'm going to decline it. Right, so here is one very important receptor which we look at all the time. It's there in lung cancer and so many other cancers now that we are finding out. So you see this is the way that the ligand causes dimerization of the receptor. And I am always taken by this analogy. It's like how people hop a ball. The fielders do it in cricket. And then there is a downstream signaling pathway that you can do. This is the MAP kinase pathway in this case. And that signal ultimately leads to several effects. It leads to angiogenesis in some situations, it leads to growth in some situations, and it also leads to cell motility. And through cell motility, you get invasion and then metastasis. Okay, so these are the growth factor receptors. Okay. Now the hallmark 2 is evading growth suppressors, and I don't need to tell you about this. There's all about tumor suppressor genes, and the ones that we talk about most is RB and T. P53 RB is the retinoblastoma gene, which codes for the retinoblastoma protein, and the TP53 codes for the P53. Now, these are known as gatekeepers. Nowadays, your Robbins talks about it as governors, whatever it is, but it governs the cell cycle, whether cells are allowed to enter the cell cycle or they are allowed to exit the cell cycle. That's what these growth tumor suppressor genes are all about. And I've just listed some of them over here. And how do you lose these tumor suppressor gene functions? You lose it through mutations, deletions, or something that silences these. The gene is perfectly normal, okay, but it is unable to be transcribed, and that may be because its promoter has been silenced by methylation, or maybe even by histone acetylization or deacetylization, as the case may be. Okay, so that's what it is all about. Now you know this, and I'm not going to go into any details, but these are all the different rare syndromes. They are by no means common, and everybody knows about the Knudsen's hypothesis. I don't have the time to go into it, but if one of the alleles is inherited and it's abnormal, if during the life of this individual you have both alleles are the other allele is lost or it is mutated, then the retinoblastoma happens. Now I want you to think about this. I'm not going to ask you to answer about it now, but isn't it strange that, say you in a family, there is the retinoblastoma gene anomaly, and every cell in the body has that abnormal gene, and yet it's only retinoblastoma that occurs. Why do we not get squamous carcinomas? Why don't we get other tumors, maybe in the colon, in the gut, in the soft tissues, or anything? Okay, we do get it in the Lee-Fraumeni syndrome. When you have P53 is abnormal in a family. Yes, you get breast cancer, brain tumors, acute leukemias, bone soft tissue sarcomas, adrenocortical carcinomas. You also get endometrial carcinomas and so many other carcinomas. But why does it not happen with the retinoblastoma gene? So I think that's something that you have to think about. Then resisting apoptosis, and you know that apoptosis is a response to a variety of developmental, physiological, and pathological needs. Do you know how you get your fingers, how fingers are formed in your hand? If you know what a hand looked like in embryological life, it's like this. It's like a fist. Nothing. It's just a blob of skin with its subcutaneous tissue and developing cartilage in that. And then what happens? This apoptosis causes loss of the in-between tissues, and fingers begin to form. So apoptosis is very, very important in developmental physiological conditions. It's also very important in pathological needs, because you don't want damaged cells to hang around, and apoptosis is responsible for making those damaged cells die. Okay, so obviously it is an important mechanism in the maintenance of cell and tissue integrity. Now think, if cell and tissue integrity cannot be maintained, okay, because apoptosis is abrogated, imagine you're going to get exactly what we described in cancer. What is that? Anvesha, what is it? Disorganization of tissue. Okay, it's for the maintenance of cell and tissue integrity, you require cells in different situations, different cells, to be able to either become senescent or to die. All right. So the main triggers are DNA damage and excessive proliferation. That's what I told you. If some things are going out of hand, then apoptosis will be triggered. And it's balanced with pro and anti-apoptotic factors. Now, this I have taken from Robbins, and I want you to, I don't want you to even look at these pictures. This is about P53, that is about RB. And I want you to do some homework, because at the end of this talk, which we will come to in the next 15 minutes, I am going to give you some homework. So please look at these pictures. They're there in the Robbins. All of you, I think, have Robbins either at your homes or in the libraries, because you are going to have to answer some questions based on what you are seeing over here. Okay, and one of the questions is right here. The RB question you will answer as homework, but here is something. Can somebody? This is an endometrium on the left hand side, and it's an endometrial carcinoma. And I've said that it is high grade and it's probably serous. Can anybody tell me what this brown staining is over there? I think it's easier if we start with the right hand side. Yes, you see this brown stain over here? This is follicular lymphoma grade 1 or 2, and this is follicular hyperplasia. So what's this brown stain? Yes, somebody said it. What?
BCL2.
BCL2. Yes, wonderful. That's BCL2. So now tell me, what is the brown stain on the left hand side?
P53.
P53. Excellent. Whoever said it? Who said it?
Anise.
Anise. Yes, it's P53. And Anise, now you will have to answer the question. We just said that P53 has to be removed, is removed from a system, and then these tumors are unable to go into apoptosis, right? So we should not see P53, right, Anise? So
Yes,
why are we seeing huge amounts of P53? It should not be there. We are seeing huge amounts. And we see this all the time, huge amounts of P53.
Yes,
and when we see progression, yes, Anis.
We said the mutated P53.
Yes, I know it is mutated P53, but I don't think I have an antibody to mutated P53. I just have an antibody to P53 protein.
Yes, ma'am.
Oh, so why am I seeing
Overexpression?
Overexpression? Do you think that this is just overexpression?
No.
No. Okay. So here is another question, and I'll ask you.
We say it is low.
Yes, Anis. You
Loss of
wanted to say something?
P53 mutation. Loss of P53 mutation.
Yeah, I know there's a P53 mutation, and P53 mutation is not allowing this, the apoptosis to occur. Okay. It is there it is mutant, the protein is mutant, but I am showing P53. And there are many mutations in P53, but I'm using an antibody to P53. So why? All right, now you think about it and come back. We will do homework next time, okay? So you've got P53 as well, that you have to do homework. Now you know about telomerase, that all cells start to, what do? The telomeres shorten as the cell differentiates and becomes senescent, okay? And that's known as Hayflick's principle, right? So there's only some 51 or 52 cycles of growth, that means mitosis, that can actually happen. And this happens because the telomeres are lost. So what happens if telomeres are lost? Yes, we know that the cell does not proliferate, but why? Why? Anybody can tell me? So if you don't know that, then that's another question. Is there anybody who's saying it in the chat box about P53 and the telomeres? Why we stop proliferating if the telomeres are not there?
Telomeres are responsible for aging effect, and P53 is not degraded.
Yeah, so whoever said that P53 is not degraded is absolutely right. Okay, P53 is normally degraded very quickly by the ubiquitin pathway. All right, mutant P53 protein cannot be degraded, and that's the reason it hangs around in the tissues, but it is useless. It cannot actually function. So there's plenty of P53, mutant P53, and it cannot be degraded, and it doesn't work. Okay, so it has no, the function is completely lost, but it hangs around. So it's like having a useless body over there that's not able to do its function. Very good. But somebody has not answered the question as to why we need telomeres to actually proliferate. In the first place, why do we need telomeres? Yes,
Someone has answered. It's Hayflick limit.
Yes, I know that. But why is there a Hayflick limit? Why can't we go proliferating forever? Hayflick just found out the limit. Okay, and then we realized that it is because of telomeres. But why? What do telomeres actually do? What is their function? So now somebody will have to tell me the next time. And I'm not going to go into how it happens. You have this there is a whole, telomerase, this whole protein has a reverse transcriptase, that is telomerase, reverse transcriptase, etc. It's in a complex which rejuvenates telomeres, and that's what cancer cells are able to do. Okay, and you see the Nobel Prize that was won. All right, then we have neoangiogenesis. And neoangiogenesis is a marvelous thing, that tumor cells promote neoangiogenesis because they secrete VEGF. Okay, they also have VEGF receptor, so it is almost like an auto stimulation of themselves. And we know that tumors fail to grow larger than 2 millimeters if neoangiogenesis is absent. Okay. Now, at some stage, we were very interested in this in Tata Hospital. Okay, because I used to do head and neck cancers, and we see this problem a lot of the time. A huge lymph node. Okay, but you can't find the primary. This is very common. It is so small that you cannot detect it, not even with PET scans. So the question that we asked ourselves is, why does a tumor grow inadequately at the primary site, yet it grows profusely at the metastatic site? Okay? And we asked this question and we answered it. And we answered it by trying to, with a hypothesis. And our hypothesis was that these small tumors, which we can't see, okay, the primary tumors, are angiogenically incompetent. So they are unable to make blood vessels, and therefore they undergo cycles of growth and cell death and growth and cell death, and never grow to larger than maybe 2 millimeters. Okay, so we took the large lymph node, because we couldn't take the primary tumor, and we compared them to those with known primaries, and we found that these metastases from unknown primaries actually had relative angiogenic incompetence. But I'm sure, I hope that some of you are thinking, hey, if they're angiogenically incompetent, then why are they growing in the lymph node? Well, we had done some work before, and that showed that angiogenesis is redundant for tumor growth in the lymph nodes. Why? Because the tumors at the lymph nodes are so full of blood vessels that they don't require neoangiogenesis. Okay, so this was some work that we did a long time ago, and it's important because if you are going to use anti-angiogenic therapy, and a lot of anti-angiogenic therapy exists, you cannot use it in the setting of this unknown primary situation because those tumors have switched off their angiogenesis. First of all, they are angiogenically incompetent, and even normal, when I say normal, regular tumors that have metastasized to lymph nodes, switch off their angiogenesis because the lymph nodes afford them a huge vascular and lymphatic supply, which nourishes those tumors. Okay, I just thought this was important because this is not just in the air. Everything has some bearing on our clinical practice. Then, of course, we have invasion and metastasis, and you will see all of the steps. First of all, the tumor has to break its basement membrane, then it has to enter into the tissues, that is through the extracellular matrix. It has to acquire motility. So epithelial cells which cannot move, they are fixed. Now they begin to get motility. Okay? And that is what is called EMT, epithelial to mesenchymal transformation. What? Why? Because epithelial cells have to acquire the traits of mesenchymal cells, because mesenchymal cells like fibroblasts, etc., have the ability to move. That's what they do. So also do lymphocytes. So also do neutrophils. All right, all of them move. So this is what is the first thing, or during this invasion process, the epithelial cells acquire epithelial to mesenchymal transformation or transgression. Okay. And the other thing that is important, and we'll talk about it in a little while, is anoikis. Okay. Now, how do these tumors actually, what do they lose? They gain all of this invasiveness, motility, all of that, but they lose something. They lose E-cadherin, they lose other adhesion molecules that make them stick together. And this is known as loss of contact inhibition. Okay, so it's the modification of adhesion molecules, and E-cadherin is a very important adhesion molecule, and all of you pathologists know about E-cadherin because it is characteristically lost in some carcinomas. And here is an in situ lobular carcinoma. Okay, it's associated with an intraductal carcinoma over here, which happens. And in this case, you see beautifully that the intraductal carcinoma has not lost E-cadherin expression. You can see the brown membrane because that's where E-cadherin is on the cell membrane. And here, these cells have lost their E-cadherin. Okay, we use it in breast cancer diagnosis. We use it in sometimes some stomach cancer diagnosis, etc. And this is how the metastatic cascade actually happens. You can look it up in your books. I don't think it's important. I don't think it's important for me to talk about it, but there's angiogenesis, motility, intravasation into the blood vessels, then survival in the vasculature. And at every spot, the tumor cells are vulnerable. And only those cells which are able to survive this journey actually reach and come, are able to get out of the blood vessels and get to the metastatic site. Okay, and all cells in a tumor may not be capable of metastasis. So the metastatic phenotype may develop over a process by clonal heterogeneity. So it starts without being metastatic. Then suddenly you get a cell which may have acquired something, the invasion, the ability to break down barriers, etc. Then it grows there, and then it may actually metastasize, and the metastasis may show you even more clonal heterogeneity, while the main tumor yes, still maintains its metastatic phenotype and gets other phenotypes because there's constant, we talked about genetic instability, and more different kinds of clones are produced in the tumor. Okay, now this is the molecular pathology of cancer. We use this in diagnosis. We look for mutations, we look for deletions, we look for amplification in HER2 and NMIC. These are amplification of various genes which are not, we look for loss of not only these, but many other genes that we look for. We look for gene rearrangements, which are common in sarcomas, lymphomas, and in leukemias. And we also look for the final end product. Is there any protein that is just like we did in P53, all right? We know it's mutated P53, otherwise it would have been degraded, okay? So by looking at the protein, we will know what has actually happened in the genome, whether there is a mutation or there is an epigenetic modification, etc. So this is, in short, the molecular pathology of cancer. Okay, I have just a little bit, before I give you the homework, I just want to tell you quickly about autophagy and anoikis, okay? And this is something that I feel is not touched upon enough. And this is about housekeeping and homelessness in cancer. Now, I'll tell you why we say housekeeping. There was a Nobel Prize that was awarded to this scientist, Yoshinori Oshumi, who made the breakthrough when studying yeast, you know, that bakers used in whether it is bread or cake or whatever. And he discovered that there are these, and of course, he did work on something that had been done by Christian Duve, but what did he discover? That autophagy takes place in all kinds of cells, and a yeast is a fungal cell, okay? It means self-eating. And what is this? All cells with nuclei have, that's what eukaryotic cells are, have this capability. And what it does is that the cell sequesters, that means it collects within a double-layered membranous vesicle. It's called the autophagosome. You know, we've heard of lysosomes and phagosomes, but here, this is a phagosome which is eating up parts of the cell. It's not phagocytosing extraneous material. And that autophagosome, it is then delivered into the lysosome for degradation. Now you might ask, why? Why do we need this kind of autophagy? All right, that's what it does. It removes long-lived proteins, damaged or obsolete organelles, okay? Toxic proteins. If phagocytosis is inefficient, then the autophagosome is formed, and it has some extremely potent enzymes which it delivers to the lysosome, and it therefore plays a very important part in infection, aging, degenerative disease, and cancer. All right, if you lack autophagy, you are, you know, various degenerative diseases have defective autophagy. So your cells are in effect so messy that they trigger apoptosis and they die. Okay, so housekeeping this is a kind of tumor housekeeping, not tumor, it's just cellular housekeeping. It provides material for metabolic reactions, repair, because it just recycles them. Okay? Proteases break down, hydrolases break down fat, sugars, nucleic acids, okay? So they clear all this stuff. And autophagy keeps cell processes intact and thereby enhances cell survival. Now, we don't want cell survival in cancer. It should, you know, these cells should be pushed into apoptosis. But if the cancer cell is able to evade autophagy, then apoptosis will not occur, okay? So that's why autophagy is a very important important part of what's going on in cancer. Makes tumors resistant to chemotherapy and radiation therapy, which should actually kill cells. But because autophagy is sometimes overactive in cancer, it's promoting cell survival. It is also clearing up all the debris that chemotherapy and radiation therapy produce, and tumor dormancy is also so it helps in tumor progression and metastasis. Now, what is anoikis? This was first, discovered years and years ago in 1994. Okay, and anoikis really means homelessness. And I showed you this diagram. When a cell loses its adhesion, epithelial cells in particular, it can happen in endothelial cells, it can happen in mesothelial cells. When they lose their adhesion to their extracellular matrix, they should undergo anoikis. Okay, why? Because the moment that happens, that cell is not supposed to be where it is, and therefore it should die. That is how nature prevents cells that are not supposed to be motile from going where they are not supposed to be. And so it triggers apoptosis. Okay? There are a whole lot of ways in which this is regulated. Much of it is regulated through integrins. Okay? And here it is. If the cell is not attached to the extracellular matrix, you get apoptosis. Now, there are a whole lot of physiological reasons for why anoikis does not happen. Okay, cells like lymphocytes, neutrophils are very resistant to anoikis because they have to be motile. They have to move from one place to another. Also, if fibroblasts, etc., are healing, if there is wound healing, then of course you cannot have anoikis. Otherwise, how will the fibroblasts go to the different parts of this healing wound and actually begin to bring the wound together? So that is, they are also spared from anoikis. But unfortunately, invading cancer cells survive as they have acquired resistance to apoptosis, and anoikis does not work in this. And that's, again, the whole story of epithelial to mesenchymal transition. And this phenomenon occurs naturally. It is activated during wound healing, inflammation, or embryogenesis. Imagine, in embryos, cells have to move. They go from one part to another. And if there was anoikis, I think that we would probably not be able to form the organs that we are supposed to form. Okay, so this is, I think it's so beautiful. All right, autophagy and anoikis are the yin and yang. Do you know what is yin and yang? Gurtej? You know what is yin and yang? Yin and yang is the two complementary parts of which in Chinese philosophy. Okay, if you have a good, you have a bad. If in every system, the Chinese believe you have, if there's death, there is life, and so on and so forth. So autophagy and anoikis are the yin and yang, because autophagy promotes survival, anoikis promotes death, of the struggle between life and death. Okay, each of us, think about it, has within ourselves the decision-making machinery to either live or die. And this is a complex interplay of factors that ultimately determines the fate of each cell. The decision is based on the internal state of the cell and that of its microenvironment. And you know this, no? Immortality is a dream that cancer cells try to achieve. That's what cancer is a lot about. Okay. So, and I just put this up because it's a beautiful poem written all the way in the 16th century. Okay, He said, no man is an island, entire of itself. Every man is a piece of the continent, a part of the main, meaning the mainland. So think about this, and the next time we will talk a lot about this, about cells not being just of themselves. They are part of a whole system, of a tissue, and the tissue is part of the body. And all of this, what does it have to do with cancer? All right. So now we have homework. All right. And here is the homework. The homework is, you may not answer the first question. I will answer it for you, okay, the next time. Why do, see, if RB and TP53 are so important in cells, and they, in the whole cell system, when they developed RB and TP53 null mice, that means they had no RB and no TP53, they developed normally. So, going on, okay? Why are only a few organs targets of cancer in the inherited syndromes? Okay, in APC, you get it only in the gut. Okay, and yes, if you have another form of APC, then you get Gardner syndrome, etc. But if you only inherit a particular form of this APC gene, why is only the gut involved? Huh? So take down these the homework. Why is P16? And we do it all the time in our labs. A surrogate marker for HPV in some systems. Okay, so P16 is a surrogate marker. It's like we use P53 in the lab, and to show the P53 protein. We also use immunohistochemistry to see P16. Okay, and the last question is, what is the pathogenesis of squamous carcinoma? Okay, just think about these things. I think there was one more that I thought that you guys should know, and what was that? That was, yes?
Role of telomerase, ma'am.
Yes, about telomerase. So you'll have to remind me about that. I will write it in the next thing. Okay. So this is some of the homework you are expected to do, and we will take the homework the next time that we start. So we'll have 10 minutes of homework, and then we will do Neoplasia part 2. So I'll say good night to you guys. Thank you, all of you. You've been extremely cooperative. All of you will not come the next time. I know that there's a whole new lot. So you don't have to answer the homework. Somebody else will have to answer the homework. But please share this homework with I'll ask the moderators to share the homework. Okay?
Sure, ma'am.
And the next lot of 7 or 8 students can answer the homework. I'm very happy for all of you to be there as well if you want to come and answer the homework. But I think you've done very well. Any questions in the chat box, or I'll
Yes,
just...
ma'am. Ma'am, we have 3 questions. One is, why are metastatic patterns of follicular carcinoma bone and papillary carcinoma thyroid in the lymph node different?
Sorry, what did they say?
So why are metastatic patterns of follicular carcinoma from a bone and carcinoma from a thyroid to lymph node different?
Metastatic carcinoma to the bone and metastatic carcinoma. Let me just stop this thing. I can see.
I think the question is why different types of tumors have different types of metastatic patterns. Why do they prefer?
Very good. So the person who asked that question probably knows the answer. Let us ask our students over here. Can you answer that question? In other words, why is there selective metastasis? Renal cell carcinoma goes to the bones, yeah. Breast carcinoma goes to lymph nodes and to then also goes to bones. But some tumors go only through the bloodstream. Yeah, sarcomas by and large go only to the bloodstream, except synovial sarcoma, epithelioid sarcoma, one or two other sarcomas. They all go by the bloodstream. Now, just take the sarcomas, okay? I mentioned two sarcomas, synovial sarcoma and epithelioid sarcoma, regularly metastasize to lymph nodes. They also go by the bloodstream. Other sarcomas metastasize by the bloodstream. Yes? So why? That's the essence of the question. Now come on.
The seed soil hypothesis.
What did you say?
Seed soil hypothesis.
Seed soil hypothesis. Excellent. Seed soil hypothesis. So what is the seed and what is the soil?
Yeah, ma'am, the tumors who are going to metastasize are the seed, and there's some sites are very fertile for them to.
Yeah, but we are talking now about like kindergarten children, no? Water the plant and the seed. But what is this? What is it that does it? We mentioned it. We mentioned all of this as part of why tumors prefer to do some things in some instances. The answer to that question, we're going to take it up the next time, but I might as well answer it. And that is adhesion molecules. Okay, there are different adhesion molecules. You notice, you know something, even when we walk, okay, my leg doesn't stick to the ground all of the time, right? What happens? Sticks, and then it lifts, and then it goes down. So this tumors actually walk. That is what is motility. Now, where it walks and how it adheres and to what it adheres is very dependent upon adhesion molecules. Okay, and so you heard a lot about the integrins. There is also selectins. So not only does how into what kind of system it actually intravasates, does it go into the bloodstream, does it go into lymphatics, yeah, is very dependent upon its adhesion molecules that are available in the bloodstream or available in the lymphatics. And the second thing is where it gets out. If it's in the lymphatics, obviously the station is the lymph node. But if it's in the blood, it could be the lungs, it could be the liver. It depends on what system it has got into. There too, whether it goes to the bones or it goes to the lungs, is going to depend upon its adhesion molecules. And it's also, I mean, it's very easy to just say adhesion molecules, but there's a whole lot more in biochemistry, and that is glycosylation. Okay, adhesion molecules are glycosylated, and they have affinities to different other glucose molecules wherever they are traversing. So it's a big study for subject, the actual how metastasis, invasion and metastasis occurs. Okay, so that's the answer. It is often dependent on adhesion molecules. Yes, this is true about lymphocyte homing as well. Okay, why do some lymphocytes go to the B area? Why do some lymphocytes go to the T area? Yeah, why do you get some lymphomas that are only in the bone marrow and are seen in the spleen, like for instance hairy cell leukemia? Why don't I get hairy cell leukemia in a lymph node? This is all dependent upon niches, and those niches have to do with homing receptors. Okay, and what do we mean by homing receptors? We're really talking about adhesion molecules. Okay, so read a lot more about adhesion molecules if you're curious about it, but don't clutter your head with a whole lot of things. But when you notice something or you're questioning something, then that's where you should satisfy your curiosity. So whoever asked the question, if they are okay with that, then I'll move on to the next question. What is it?
Yes, ma'am. The next question is, can checking for autophagosomes be helpful in early detection of malignancy?
No, I don't think that looking for autophagosomes are early detection of malignancy. But there is a lot of work that is going on exosomes. Okay, what are they? They are little bits of the cytoplasm of tumor cells. Okay, you know that all our cells, whether they're normal or abnormal, they shed pieces of their cytoplasm. They also shed pieces of cell-free DNA. Okay, now that is extremely interesting, because we're talking about liquid biopsies now. Yes, so if I take blood and I am looking for a mutation against, like is an EGFR mutation. I know that this patient has got lung cancer. I want to know if the lung cancer is completely regressed. So I can look to see, after a certain period of time, I will do a liquid biopsy. I'll find out whether that EGFR DNA with the EGFR mutation is present in the blood, right? And if it's present in the blood, it means that somewhere there is, the tumor is there. The second thing that it can do is, say the patient has stopped responding, and we'll talk about that the next time. But since somebody asked the question, I will answer it, and you guys can read up a little bit more. If somebody has stopped responding to disease, and I want to know why, maybe there's been a resistance mutation. And if that resistance mutation is found in the circulating DNA, then I know that that's the reason why this has stopped responding. I can also, because somebody asked about early diagnosis, exosomes, okay, which have in them, they're pieces of cytoplasm which also have some DNA, etc., in those cells, can be, examined for. You can't do all of the genes, but you can do some common genes for common cancers, and you may be able to discover that the patient has a cancer. But I think it is the most ridiculous thing to do such a thing. Okay, why? And the why is important, and I will tell you about it the next time. Why this kind of early diagnosis of cancer should not be even indulged in. Okay, because we will talk about the perils of trying to do early diagnosis of cancer by these means, because one of the things that we're going to discuss is a cancer cell definable by and of its self. Okay. Any other question? There was the third question.
Yes, ma'am. In relation to tumor cell metabolism, if we cut down sugar consumption to nil, somehow prevent gluconeogenesis, can we shorten cancer cell survival?
You live without any carbohydrate, because all carbohydrates, you may not take any sugar, you may not take any fructose, you may not take any sucrose, but can you live without carbohydrates? And the answer is no. Okay, whether you're eating rice or you're eating pasta or you're eating whatever, ultimately what happens, it gets converted into glucose, yes or no? And it gets stored. And imagine you're not eating any glucose to starve your cancer, but ultimately the cancer is starving you, right? Because it's anyway starving you by taking away the glucose that you are. So there, you are cachectic as a result of the starvation that the cancer is producing, and now you're trying to starve the cancer. It's a little bit, I don't think it makes sense. You starve the cancer of nutrition by using anti-angiogenic agents. You stop the cancer from, sort of getting blood supply, and that's one of the therapeutic measures that are being tried, particularly for, that anti-angiogenic agents are used even to treat benign tumors. They're used to treat, sort of hemangiomas, etc., in the eye, because you can use the anti-angiogenic agent to actually shut down the vascularity in that particular region. It's fraught with a lot of complications and sometimes some very untoward effects. But if there is a reason to use an anti-angiogenic agent, you can use it. So that is part of the whole thing. So please don't even try to cut down your glucose because you're only being counterproductive. Anything else? Yeah, Shrutika?
Sorry. Ma'am,
No, no.
last question. In the context of low angiogenesis, tumors have a lower metastatic possibility?
In the context of low angiogenesis?
Yes, ma'am.
Well, that's an extremely interesting question. So you might ask if there is, if the tumor is only allowed to grow for 2 millimeters and there's constant apoptosis and growth and apoptosis because the cell is growing and dying and growing and dying because it can't grow more than 2 millimeters. Okay, but as we will see a little bit later, when you have such a tumor and it has undergone many cycles of apoptosis, that tumor has to reach that small size. Imagine the number of cell divisions it has actually undergone. Okay, it's growing and dying and growing and dying, and it's just that 2 millimeters in size. So the number of cell divisions it has gone through makes it very vulnerable to develop a metastatic clone. Okay, because clones will develop in a tumor during cell division. No, you can't suddenly get a mutation. The mutation has to occur during cell division because that's where the instability of the entire genome is under threat. Okay, the stability is under threat. So imagine this small tumor is a very old tumor. It may be 2 millimeters in size, but it's a very old tumor. And in that tumor, there's been, countless cell divisions. And as a result of those countless cell divisions, the chance of a metastatic clone developing is very, very high. And that metastatic clone, it's a very small tumor, it's 2 millimeters, but that does not preclude that small tumor from actually invading and getting into whatever little, space that it has, have epithelial mesenchymal transition, and off it is to a metastatic site. And that is why you get this peculiar thing of a small or an undetected primary and a huge metastatic tumor. Okay, so any other questions?
How do some benign tumors metastasize?
Same way that that malignant tumors do, except that their growth potential is very limited. Just because something metastasizes doesn't mean that its growth potential is huge. We confuse metastasis with growth, okay? And it isn't so. Once in a way, you may have a benign tumor which has some cells that get into, they intravasate and extravasate somewhere, but it is so rare, and its growth potential is very limited. It just managed to get into a vessel. Maybe it got, it underwent an EMT, then it reached somewhere and it grew, but it grew as slowly as it would have done at its primary site. Okay, so I don't see any contradiction in a benign tumor actually showing metastasis. The fact that it very, very, very seldom does, it's so rare that we remark upon it and we write papers on things and we call them benign, metastasizing, this or that, just speaks of the fact that it has very limited growth potential. Okay? Any other questions?
Yes, ma'am. If exosomes are supposed to be present in advanced tumors, then how do we detect them early?
They're not in advanced tumors. They're in any tumor. I have exosomes from my normal cells that are being shed. Okay, so normal cells shed, they shed pieces of their cytoplasm, pieces of their DNA and exosomes. So the only reason that we know that the during liquid biopsy that these are abnormal is because we don't expect to see mutations in normal cells. So we're looking for mutant thing. We're doing an NGS. And what is an NGS? We've got a whole panel of genes, okay? And we are doing this with massive, parallel sequencing. And we're looking at what sequences we're getting. And if they are normal, then there is nothing, that there is no tumor. But if it's abnormal, then we have to assume that it's come from an abnormal cell. And I will address the next time why this is so, it's dangerous, it's downright, I think, ridiculous to want to detect cancer when you don't even know where that cancer is. So it's going to become a hunt, no? I've got something mutant. Now where am I going to find it? And then, the patient, if you were the individual, would you sleep at night knowing that somebody found a mutation I went to find out, my mother used to use a term, it was called, in Konkani, Viktipida. It means buying trouble. So, trying to the holy grail of finding that first cancer cell, I will tell you all about it the next time. Okay? That is or should not be the holy grail. Yes, Shrutika.
Yes, ma'am. So where do we presently stand in the era of theranostics and liquid biopsies in the early detection of malignancies?
I would not even talk about early detection of malignancies. I just told you that I will talk about it the next time. Theranostics cannot be used for early detection. If somebody is interested in theranostics, when we come to that part, I will tell you what it is. But I think we'll leave theranostics to another day. Okay, it's a whole lecture. So
that's all for tonight, ma'am.
All right. Who's this person who's asking about theranostics, etc.?
It's Harshad Aparajit.
All right. So Harshad, we will have a chat about it. I don't think we should confuse these young people anymore. Send me a question and I'll answer it on email. Okay. But if these young guys are interested, the next time ask it again and we'll discuss. There I see Sumit. Hi. Okay. So next time we'll have the other lot, but please share the homework with them. Yes?
Yeah.
I think Shrutika and Sindhura will. Okay. So good night, everybody. Thank you all.